All right. Good afternoon, everyone. This is a great session coming up. My name's Tim Henry, and I am interventional cardiologist at Christ Hospital in Cincinnati. And I apologize for being casual, but I just scrambled to get here from the airport. So the fact that we're here is success number one. And we're going to introduce my co-moderator and then panelists. If you can just introduce yourself, and then we're going to get started.
I'm Andrew Higgins. I'm one of the heart failure and critical care docs over at Cleveland Clinic. I, too, am a survivor of flying United from Ohio to Houston recently, so I feel your pain. And Dr. Hollenberg?
Steve Hollenberg, cardiology and critical care, Emory in Atlanta.
Maya Guglin, heart failure transplant, Rutgers, New Jersey.
Manpreet Kanwar, heart failure cardiologist, University of Chicago.
Daniela Becker, intensivist, Brussels, Belgium, Europe.
And Ayaz Sachedina, interventional heart failure in Calgary, Canada.
Great. So I'm excited about this. We have some great debates, and 3 great debates, and then we'll have time to discuss. But our first one is pro or con, acute myocardial infarction, and revascularization is superior to unloading. And taking the pro is my good friend, Dr. Sandeep Nathan.
Okay. Wow, such a pleasure to be here again, and this meeting has just grown. Congratulations to Dr. Card, to Dr. Jumian, and the planning committee. Okay, so in the 7 minutes that I have, my task is to convince you that revascularization is better than unloading in AMI shock. I'll open with a quote from Nietzsche. There are no eternal facts as there are no absolute truths. And so a lot of this is perception and how you interpret the data, and are you a glass half full or glass half empty kind of person. So let me frame this with a case. 80-year-old patient, frail woman, lots of medical comorbidities, CKD, transplanted kidney, and so forth, comes in with a STEMI, which looks like this. She is hypotensive. Her MAP is 63. This becomes important later. And she's loaded with dual antiplatelet therapy, heparin, and so forth. She started on dopamine both for her dropping blood pressure as well as her dropping heart rate, and she's sent up to the cath lab as an activation. This is all the lab data that we have. A lactic comes back later on at 4. But you can see that she's not doing well. So the peripheral angiogram is interesting because you can see lots of calcium, popcorn. The distal aorta has disease as well, and you can see what the guide wire is doing on the calcium. So this sort of helped inform our decision that perhaps we weren't going to veer towards mechanical circulatory support and unloading in this patient. RCA looks okay. And the left system shots identifies the problem. There's a left main lesion. The circumflex is out. The LAD is impacted by it as well. So as with most of my major life decisions, I consult Twitter. I'm kidding. This came later. Just wanted validation. And so, your 4 options here are stabilize an emergent CABG, PDCA of the circ and urgent CABG, no stent, DES of the circ, and come back for the LAD, or fix it all with or without mechanical circulatory support. And that's sort of the crux of this discussion. We have quite a bit of data that came out in the last few years to help inform this decision. Of course, the preclinical data for door to unload suggests that unloading in acute ischemic shock for 30 minutes seems to be the most favorable approach before going on and opening that vessel. And of course, we've got the pilot study. The problem with the pilot study, though, is that by play of chance, there's a 24-minute difference in ischemic time between the 2 groups. So the total ischemic time in the delayed reperfusion and the immediate reperfusion group ends up being more or less the same. So that's number 1. NCSI, published by Barbara Basir and colleagues. I was just in a meeting with Barbara. This is an incredible publication that shows that 71% survival to hospital discharge in AMI shock. The problem here in unloaded patients is that this is being done by extremely competent operators that rinse and repeat over and over and over. So the question is this actually replicable? And then, of course, there's danger shock. 355 patients enrolled over 10 and a half years. demonstrating for the first time the superiority in a randomized fashion of a device-based strategy in revascularized AMI shock. And the Kaplan-Meier curves, I think, are seared into everybody's brain by this point. Shows an early separation and a continued divergence all the way out to 180 days. And so the headlines read that Impella CP is associated with improved survival in AMI shock compared to standard of care, but with an increase in bleeding and vascular complications. The devil is often in the details, however, and we got to learn some of the details last week. This is the picture that we took, Manrit, up in the Sky Lobby. We got to learn from Dr. Jacob Moeller some of the details of danger shock, including the fact that many subgroups had considerable effect heterogeneity. So those were female patients, older patients, patients with blood pressures, MAPs of greater than 63, non-anterior MI with shock. So our patient hits several of those. And many more issues were raised in this, this editorial published by Holger Thiele and colleagues. 12 points that they sort of focused on, but really relevant, I think, to the US population is that very highly selective eligibility criteria, excluding the out-of-hospital cardiac arrest patients, many of them, the open label design, the fact that in the Impella arm there was escalation to ECMO and Impella 5.0 was all cited as potential issues. And then finally this was published just a couple of years ago from Vancouver. In nearly 3,000 patients with STEMI, about 9.5% had cardiogenic shock. And look what happens in increments of 10 minutes between 60 and 90 minutes. There is a marked increase in morbidity and mortality the longer you wait in those patients. On the other hand, the blue line is flat. The non-cardiogenic shock patients, not saying that we should burn our time, doing this and that in non-shock patients. We know that, time is myocardium. But in the cardiogenic shock patients, time is also mortality. So the longer you delay, the more likely you are to have problems. So if you are going to unload, you got to do it effectively and quickly and without incurring additional issues like bleeding and vascular complications. So back to the Twitter poll, the plurality of people voted for fixing the circ and staging the LAD, which is, of course, not what we did. We ended up doing a DK crush without mechanical circulatory support, 6-wrench long sheath for support, and I won't go through all the 37 steps of DK crush, but suffice it to say that we did all the things, and we did intravascular imaging, we did calcium modification, we just worked very, very quickly, including short pulses with shockwave in the left main, and very good technical result in the end. So the case conclusion, patient did very well despite the fact that she wasn't unloaded. We removed the sheath in the cath lab. We did a quick right heart cath to make sure that we didn't need to escalate at that point. She wasn't deteriorating. That was all very reassuring. She was loaded with Tycag and Cangrelor. Dopamine was weaned off on hospital day 1 in the CCU. She was discharged home on hospital day 3 and has done well for about 6 months. So the key takeaways here are that expeditious revascularization in AMI with or without shock remains the single most important intervention, and delays to revascularization can increase morbidity and mortality in AMI shock. There's data to support this. There is certainly data for unloading in AMI shock, most recently DANGER. But these data are somewhat limited by the selective nature of the population study, the very high level of technical expertise, questioning the replicability of some of those findings, device escalation in the Impella group, lack of benefit in certain key subgroups. And so at the end of the day, it's rarely a question of unloading versus revascularization. Pick one. The question is, can you make both of those things happen simultaneously? Thank you so much.